Good evening, ladies and gentlemen, and welcome to the Center for Independent Studies. My name is Oliver Hartwig. I'm a research fellow here at the center. It's my great pleasure to welcome you to tonight's event. I'm doing something now that is perhaps not quite appropriate, but there simply hasn't been a better time for this. I just have to announce that after 3.5 years at the center, I'm actually leaving Sydney, and I've just been appointed for a new role in New Zealand as the executive director of a New Zealand think tank. And I just wanted to take the opportunity to thank you all, our longtime supporters, for your support over the years. It's been a great pleasure to work here, and it's been a great privilege to work with colleagues like Jeremy Sammut. Working in a think tank like CRS is all the better for having colleagues like Jeremy, who is extremely versatile, as many of you know. Jeremy is a historian by training, and he has a PhD from Monash, and in his PhD thesis he worked on Australian political and social history. But then in his think tank work he has become one of our most versatile researchers, and it's been a privilege working together with Jeremy over the years. He has made a name for himself in very different areas, in child protection more recently, but also and predominantly in health policy. And this is exactly what he's talking about. So he's bringing his different perspectives together, his historical knowledge of Australian political and social history, and his in-depth knowledge of Australian health policy. And he applied his knowledge, assessing what the former New South Wales Labor Government did over 16 years in office. Jeremy has written a chapter for a compilation on the assessment of the 16 years of the Labor Government under King Carr, as it was called in the events description. Now, of course, Mr. Carr has since moved on to other ventures, as we all know, but it is still worth examining what he did when he was in charge of New South Wales, of the state government, because there are lessons to learn here for the state government, not just lessons that apply to historians in assessing the legacy of the Carr government, but lessons that have a deep relevance for today's policy developments, and especially for Mr. Carr's successor, of course, the O'Farrell government, and we are still awaiting the great reforms that O'Farrell promised initially when we elected him, right? So, without further ado, I would like to hand you over to Jeremy. He will speak for about 35 minutes, and afterwards we'll have time for questions and Jeremy's answers. Thank you.
Thank you, Oliver. Hello, ladies and gentlemen, and thank you for coming out this evening. There are three main things that I'm basically going to be talking about tonight. The first is to give you a sketch of the chapter that I co-wrote with David Gadiel on the health policy of the former New South Wales Labor Government, which is published in this book, From Carr to Keneally, which was released last week. The second is to consider some of the policy lessons that the chapter contains, which I think are highly relevant to the health reform agenda of the O'Farrell government. And thirdly, I want to make some observations about our co-authoring of the chapter. For this was a rather unusual occurrence, because it's not every day that two people who are associated with a free market think tank, such as CIS, are let into the hallowed halls of labour history, by the academic gatekeepers at least. Having said that, writing the chapter could slightly be seen as a bit outside the remit of a think tanker. However, the reason that I agreed to be involved with the book was because I thought it would give me a different way to examine one of the most persistent public policy problems facing all state and territory governments. And I felt that by studying where New South Wales Labor went wrong in health, I could get a better understanding of what needs to be done to improve the performance of the public hospital system. Now, I think this has been a very fruitful process in terms of formulating policy prescription. And for that, I have to acknowledge my huge debt and CRS's huge debt to David for agreeing to work with me and for generously sharing his experiences in the health industry, which are legion and long-standing. To start with our chapter, now this is not the intention, but in retrospect, one of the things it does is debunk one of the myths that has developed about the former New South Wales Labor government. And the myth is that it was largely a good government in the main under Premier Carr, and the rot only set in after Carr resigned in 2005. Now, the rot is generally agreed to have consisted of a mix of the following: excessive spin, pandering to vested interests, pork barrelling favoured groups, and poor policy with a focus on short-term media and political cycles. But when you analyse the performance of the Carr government in such a key area as health, what you find is the rot set in very early in the Carr era, and I would argue that the bad qualities I just listed were in fact part of the Carr governing style virtually from the get-go. In health, Carr's flawed governing style and the resultant policy failures principally concern the contentious issue of hospital planning and rationalisation. In the fullness of time, this contributed to the scale of what has commonly come to be referred to as the hospital crisis. Now, it was the hospital crisis which spanned events such as the nurse whistleblower controversies at Camden and Campbelltown Hospital, and which culminated in the miscarriage of Jana Horska in the public toilets at the emergency department up at Royal North Shore in 2007. It was these scandals that generally became associated with the perceived failures of the Emma, Rees and Keneally governments. Now, the overall argument of the chapter is that the policies Labor pursued did not adequately address the fundamental structural problems with the New South Wales public hospital system. Now, the context for this argument is that the system is high cost and low performing. New South Wales health expenditure is now over $16 billion a year and represents over a third of the state budget. If expenditure continues to grow at the current rate, health will consume the entire state budget in 20 years' time. But despite high and ever-increasing spending, elective waiting times have lengthened in New South Wales compared to other states over the last decade. Now, what we claim is that the fundamental structural problems that went unaddressed, our claim that Labor failed to address the fundamental structural problems with the system over the course of its 16-year reign is based on what the chapter describes as the core reform agenda that needs to be pursued if the system is to be properly managed. This is assuming, of course, that Medicare remains Commonwealth policy and the states remain obliged to provide free public hospital care without any user charges. Now, the first item on this agenda of what we think is an optimal reform agenda is achieving cost-effective distribution of scarce resources across geographically dispersed communities, both within metropolitan and rural and remote New South Wales. The second item is the need to develop a financially accountable devolution of hospital management by employing market-based initiatives. This is necessary to remove the rigidities, inefficiencies and excessive centralisation of the current command and control administrative system. Under this system, local hospitals are run via the area health services as de facto branch offices of New South Wales Health. So there are in fact three elements to this core agenda, and they cover planning, governance and management, and microeconomic reform of the traditional public service monopoly model of public hospital care. And this is a model which, thanks to the structural reforms of the last 30 years, we've recognised as has outlived its usefulness in virtually all areas of government activity, except for the public health sector. What the planning issue basically comes down to is that New South Wales has 150 public hospitals. Some are located very close together, and in general their locations reflect the medical and transportation realities of the late 19th century. When the system was founded over 100 years ago, every small country town and suburb needed its local hospital. But with the development of technologically sophisticated and specialised hospital care, the provision of all services at every location is now financially and logistically impossible and is clinically inappropriate and often unsafe. Optimising the system amid limited budgets and competing priorities across the whole of government depends on a judicious mix of the following. 1. Closing or redefining the role of small rural hospitals and concentrating more complex services in larger regional and metropolitan facilities. 2. Avoiding duplication in metropolitan areas by merging and relocating services. 3. Developing an appropriate mix of core and specialist services in outer metropolitan growth areas. And 4. By striking the right balance between 1, 2 and 3, ensuring that sufficient recurrent resources are available to run services efficiently. And I'll talk about that in more detail soon. Now, studying the problems and articulating these principles is the relatively easy bit. The hard bit is that the necessary reorganisation requires the political will and leadership to justify it to a sceptical public. What hasn't been adequately confronted in health is the parish pump mentality, which is often advocated by local politicians, which demands that all services be available locally. What isn't realised, and this is due to lack of political leadership, is that what this mentality means is that the quality and quantity of care that the rest of the community receives is lower than it should be. Because for political reasons we do things like pay hundreds of thousands of dollars to doctors to work as locums in hospitals that treat very few patients and should really be shut, funding has to be spread so thinly on the ground as to compromise the hospital system's overall capacity and sustainability. So we end up spending more than we should to get less of the care we should receive for what we spend. Having said that, since 1995 there has been some progress in concentrating specialised services in larger metropolitan and regional centres of excellence, and some smaller local country hospitals have been reinvented as multi-purpose services. But unfortunately, the Labor government only unevenly implemented these sound planning principles across the state because they inevitably meant significant change for many smaller country and metropolitan hospitals. Hospital closures and downgrading services by past Labor and coalition governments have always been unpopular, especially in country areas where hospitals remain a major source of town employment and a mainstay of local businesses. However, what David and I point out in the chapter is that many of the difficulties Labor experienced in health can be attributed to the Carr government's failure to implement the Labor Party's own planning policy. When it was elected in 1995, Labor's health policy consisted of a Beds to the West strategy, which aimed to improve the equity of the system. Recognising that Sydney's population had shifted westwards, this policy was designed to reverse service and funding imbalances, which favoured long-established hospitals in inner metropolitan, central and eastern Sydney. The plan was to redirect resources to underserviced catchments with expanding populations and politically sensitive seats. In June 1996, the Deputy Premier and Health Minister, Andrew F. Shorgie, announced the merger and relocation of St Vincent's Hospital, Darlinghurst, to St George's Hospital in Kogarah. Savings thereby generated, together with other planned closures, mergers and downgrades, were to fund expansion of services across the western suburbs. Now, the apparent proof that Labor was serious about improving the equity of the system prompted an outcry by clinical and administrative staff, which led to some negative media coverage, quite loud and vociferous media coverage. Political expediency then led Carr to intervene, to cave into vested interests and overrule his deputy's policy just 11 days after the closure of St Vincent's was announced. The short-term response to the political pressure scuppered Labor's restructure of the health system at the first hurdle, with long-term adverse consequences for cost, performance and sustainability. Defenders of Carr would point out that the government went ahead with a large capital works program, which built or updated many new facilities in outer metropolitan regions. That's true. However, the failure to implement the planned service redistribution from the inner city seriously compromised the efficiency and capacity of New South Wales Health. Overcapitalisation of the public system in bricks and mortar infrastructure imposed large fixed operating costs on the health budget, which necessitated offsetting reductions in clinical budgets across the board. By the early 2000s, this occasioned widespread complaints of underfunding and meant that some units often remained underutilised due to chronic shortages of recurrent funding for frontline services. The overall effect of overinvestment, inadequate recurrent funding and underutilisation was bed and other service shortages. This included overflowing emergency departments and longer waiting times for elective treatment, which by the mid-2000s had become the chief symptoms of the hospital crisis. Despite the Labor government's subsequent efforts to develop a clinician-led planning process, hard decisions about hospital rationalisation were again not made. This is one of the most important but most politically inconvenient and thus largely neglected findings of the 2007 Garling Commission into the public hospital system in New South Wales. Garling concluded that, despite the need of extensive rationalisation and despite the existing configuration being unsustainable, no systematic, open and candid attempt at reconfiguration had occurred. What Labor largely did instead was what all governments do, when they are unwilling to take hard decisions. It found a convenient displacement activity that could pose as reform. This took the form of multiple revisions of the governance or management structure of New South Wales Health, in what proved a futile effort to address long-standing dissatisfaction with the centralised area health service administrative system. Originally, there had been 23 metropolitan and 23 country area health services established in the mid-1980s. The Carr government cut the number to 9 and 8 respectively in 1997. In 2005, then Health Minister Maurice Yemma further cut the number of area health services from 17 to just 8, covering the entire state. Under all configurations, the same complaints have been made. Management is too remote, there's too much bureaucracy, and greater local management of hospitals is needed. The Garling report reiterated these criticisms when it described the 2005 reorganisation as having created a schism between hospital managers and frontline staff. But before the Labor government could act on Garling's recommendation that managerial authority be devolved to the local level, state initiatives were swamped by the Rudd-Gillard government's national health reform agenda. The upshot of the 2010 national health reforms was that in return for extra Commonwealth funding, states and territories agreed to establish local hospital networks, LHNs. In New South Wales, this meant that 17 LHNs replaced New South Wales's 8 area health services. Ironically, the Federal Labor government's achievement and the New South Wales government's final act in health was to re-establish a structure that was virtually identical to the one that had been discredited and abolished a few years before. The New South Wales disease of displacement activity had gone to Canberra and boomeranged back again. The federal government is still eager to claim that its reforms put local communities back in charge of health services. To understand how chimerical this is, you have to understand that the federal agreement assured New South Wales Health's position as statewide system manager. Ultimate responsibility for service planning, and most critically, control over statewide industrial relations in health, remains centralised in the remit of the Health Department. What also needs to be pointed out is that all the rhetoric that comes from both sides of politics about restoring local management of health services is meaningless unless their policy insists on stringent financial accountability. This is the key point too often overlooked in all the talk about the need for local management. Hospital administration was centralised in the mid-1980s, in part to try to fix planning anomalies. But this was also necessary to establish greater financial control over the system. Prior to the introduction of the area system, local boards ran hospitals. Boards, however, were prone to overrun their budgets, then lobby government for a bailout by the New South Wales Treasury. They could do this with relative impunity because their financial accountability was diffuse. This was because financial risk, or ultimate responsibility for their debts, was held by the state government. If the governance riddle is to be solved, then health policy needs to combine local management with financial accountability by challenging the greatest taboo of all. The privatisation of the delivery of public health services needs to be embraced by policymakers as part of a comprehensive microeconomic reform agenda. In this area, policy went backwards during Labor's time in office. In 1995, Labor inherited the first for-profit public-private partnership, PPP, hospital in New South Wales from the Coalition. In December 1992, the Greiner government had entered into a 20-year contract with Healthcare of Australia Proprietary Limited, a subsidiary of Main Nicholas Limited. In return for the New South Wales government agreeing to cover capital and operating costs, the company agreed to build and operate Port Macquarie Base Hospital to replace the ageing Hastings District Hospital. The new hospital opened in November 1994. What was so significant about the Port Macquarie PPP was that it fundamentally changed the role of New South Wales Health. Instead of operating as both funder and provider of centrally coordinated services, New South Wales Health became an arm's length purchaser of health services. Establishing a purchaser-provider split and permitting private companies to operate public health services promised to deliver efficiency gains and operational savings through the adoption of business practices usually foreign to public hospitals. PPPs also promised to solve the governance riddle by ensuring hospitals were independently managed. Port Macquarie Hospital enjoyed managerial autonomy from New South Wales Health because the purchaser-provider split also devolved financial risk for the hospital's entire budget onto the private operator. Because of the threat all of this posed to the traditional public service monopoly model, New South Wales health unions and other ideologically inclined critics embarked on a campaign to discredit the model and make the PPP contract unworkable as soon as Labor came to power in 1995. The unions played to the ideological sympathies of Minister Ref Shorgi by campaigning for the replacement of private sector awards with more generous public sector wages and conditions. Plans for nurses to work with TAFE-trained nurse assistants were also opposed, as was the outsourcing of cleaning and other services. There was an upper house inquiry held at the behest of the unions, but that gave the hospital a clean bill of health. Nevertheless, the ideological conflict ultimately bore fruit. At health union bidding, the supremacy of the public monopoly model was reasserted when in February 2005, New South Wales Health repurchased Port Macquarie Hospital at a buyout cost of $87 million. To further satisfy the unions, the New South Wales Nurses Association, in particular, a revised PPP model was adopted in 2001, which limited outsourcing to so-called non-core services such as construction, catering and cleaning, and excluded core clinical services covering nurses, doctors and allied health. Clinical services are obviously the most costly and obviously most critical part of a hospital's operating budget, with nursing the single most costly item. The statewide health industrial relations systems is the centrepiece of the restrictive public monopoly model. The revised PPP model basically guaranteed that statewide nursing awards and patient-to-nurse ratios would remain sacrosanct. These features of the system deny hospital managers the ability to control their clinical workforces and the terms on which they can hire and fire. The lack of workplace flexibility includes lack of authority over visiting medical officers and staff specialists who have the right to admit private patients into public hospitals and largely control their own work schedules and work practices. Hence in the New South Wales public health system, there are a plenitude of government-protected jobs at attractive wages, but the inability to introduce innovative and efficient health labour practices has major implications for productivity and ultimately restricts community access to quality hospital care at the least cost. So telling the tale of the Labor government health begs an obvious question. Has much changed in the year since the O'Farrell government was elected? The answer to this question will be provided in a new paper that David and I have written, which will be published in a couple of weeks by the CIS. Its subtle title is How the New South Wales Coalition Should Govern Health. In this paper, our answer to what's changed is that not much has. There is no evidence that I can see that the O'Farrell government is serious about undertaking overdue service rationalisations. By default, the revised PPP model inherited from Labor, limited to non-core building services, appears to have been retained. And there's no evidence of a renewed push to revive the original for-profit PPP model and develop a genuine arm's-length purchaser-provider split. Most tellingly, the centrepiece of the O'Farrell government's policy is yet another administrative reorganisation, the fifth reorganisation in 30 years. Like those that have gone before, the Coalition's restructure is unlikely to achieve its ostensible aim of local management of health services. In reality, the Coalition's restructure is largely cosmetic. It has re-established an administrative system consisting of the same number of local health districts, LHDs, with precisely the same boundaries as the local health networks the Keneally government established in 2010. The band or the badging has changed, but the song remains the same. What we predict in the forthcoming paper is that command and control management of New South Wales health will remain the norm. This is because, under the Coalition's revised governance arrangements, LHDs will not genuinely be the independent managers of health services because they are not truly financially accountable. Financial risk will continue to be held by the state government, and there will be no expectation that LHDs should commercially manage their assets, including rationalising underutilised facilities in order to meet financial and service targets. The Health Department, also rebadged as the Ministry of Health, is thus likely to retain a high level of involvement in operational matters, including service planning, to enforce financial control and prevent LHDs from blowing their budgets. Ideally, there should be a contestable market developed for New South Wales public health services. LHDs should look to outsource the management of public hospitals to private operators via PPPs. They should also be able to purchase services from competing private hospitals. They should also be able to purchase from other public hospitals outside their boundaries. LHDs should also have the power to borrow, be made responsible for their debts, and be allowed to retain surpluses as a reward for innovation and good performance. But microeconomic reform is unlikely under the so-called new district model. Most importantly, control over the terms of employment of the clinical workforce will also remain a state responsibility. This will mean that restrictive work practices will continue to have major implications for the capacity, productivity, and cost effectiveness of the public system. In sum, therefore, much of the critique of the former Labor government's record in health applies equally to the policy of its successor. Firstly, difficult decisions concerning hospital planning, financing and management ultimately remain hostage to professional resistance to hospital closures and downgrades. 2. Romantic attachments to local hospitals as symbols of community life are still a barrier to sensible planning and impedes rationalisation of the system. 3. Public sector union hostility and provider capture continues to stymie market-based reforms which could encourage systematic renewal of an outdated public monopoly service model. And 4. Repeated administrative upheavals don't deliver genuine devolution of management because they do not contain real incentives for proper financial accountability. So finally, I'd just like to reflect on what it was like after working at CIS for over 4 years, a bit longer than Oliver, to reconnect with the academic culture by being involved with the book. What I'm about to say is not particularly new or surprising, but I thought it might be worth pointing out to at least put it on the record. Last year, the editors of the book, From Carr to Keneally, organised a seminar so that the authors could give papers on their chapters. And it's fair to say that I found the atmosphere a tad chilly. I didn't really mind that some contributors gave me wary looks and didn't really want to engage or talk to the free market pariah. It's an attitude that you have to sort of get used to if you want to work at CIS. But what did frustrate me, if not surprise me, was when I heard that one commentator made the comment that he was no longer sure he wanted to be involved with a project that involved so-called right-wing people. This was hardly the sort of spirit of open inquiry and scholarly debate we might expect from academics whose first loyalty ought to be to the pursuit of the truth. But what it of course reflected is what I've found throughout my sojourn in the universities is the intellectual conformity and partisan biases of the Australian Academy in the humanities and the social science at least, where barracking for Labor is relatively commonplace. This is also in large part the reason why many academics are innately hostile to the very existence of CIS, based on the idea that we must be as intensely partisan and as political as some of them often are. And this is despite the fact that what we actually do is offer an almost lone counterpoint from a free market perspective to what I recently heard described as the 39 so-called progressive think tanks in Australia, otherwise known as universities. Because I found the reactions to my involvement in the book both amusing and irritating, I'm really glad that the CIS is going to publish this new paper, which in essence is critical of the federal government's approach to health from a very similar policy perspective to the one employed to criticise Labor's record in the book chapter. So outside whatever this work might achieve, pointing to it as an example of what CIS does might serve as a useful repost to those who prefer to shoot the messenger rather than engage in the battle of ideas. It might perhaps help to neutralise the insult that gets held at CIS all the time, which is that we are just a front for the Liberal Party. Thank you.